Okay. Assalamualaikum and good afternoon. Uh, so far the drilling has paused. We'll see how it goes. So today we'll have a general club presentation by Syahidah on some publication by the European Society of Intensive Care Medicine. Basically, is their CPG on fluid therapy in adult critically ill patients. Basically, there are two parts. One regarding the choice of resuscitation fluids, and second on fluid therapy in clinical specific clinical scenarios, which will be presented at a later time. Without further ado, Syahidah.
Okay, thank you, Dr. Ami. So, Assalamualaikum and good afternoon, everyone. I'm pleased to present our General Club presentation for today. Topic on the European Society of Intensive Care Medicine Clinical Practice Guideline on Fluid Therapy in Adult Critically Ill Patient, Part 1, which focus on the choice of the resuscitation fluids. So, actually, the ESICM guideline consists of 3 parts. And it focuses on the CPG for the European for fluid therapy in ICU. So it is based on great methodology and also the RCT's evidence from the literature. So a bit of recap regarding the great methodology. So what is great methodology? It is a systematic and transparent approach used to rate the quality of evidence and also strength of clinical recommendations. It is widely used in international clinical guidelines, including in this 2024 ESICM guideline on fluid therapy. It helps to answer 2 key questions in clinical guidelines. First, how certain is the evidence? And second, how strong should the recommendation be? So first, the certainty of evidence. So according to the great methodology, it categorizes the evidence into 4 levels based on how trustworthy the findings are. So in the ESICM guideline, most of the recommendations are based on low or very low certainty of evidence, which means we should apply them cautiously and according to the patient context. Okay. And then regarding the strength of recommendations, a great methodology give either strong recommendations in which the recommendation is used in the most patients in most setting, and then conditional or weak recommendations which consider the intervention but recognize the need for clinical judgment and also patient preferences. And all the 11 recommendations in the ESICM 2024 guideline are conditional recommendations. And this is how the guideline is developed. No? So the team consists of multidisciplinary panel, which consists of intensivists, nephrologists, hepatologists, pharmacists, and also grad expert. And the panel included methodologies to ensure guideline quality and also objectivity. And the clinical questions we use, they use the PICO format, which are the population, intervention, comparator, and also outcome. So in this guideline, the population that we focus on is critically ill adult ICU patients. And then the part 1 focus on the fluid choice, albumin, crystalloid, and also hypertonic solution, and then the outcome. So the outcome that they look at is the mortality, the renal replacement therapy, AKI, and also the length of ICU and also hospital stay. And then they conduct systematic review and also meta-analysis using literature search conducted up to year 2023 September, and it includes high quality systematic reviews and recent RCTs. And they did a meta-analysis performed using both the Bayesian and also frequentist models, and evidence synthesized for each clinical question. So basically, there are 11 questions that we address in this guideline. And the fluid types cover include the crystalloids, which are the isotonic, saline, and also balanced crystalloids. And then colloids, the albumin, and other colloids, for example, hairs and also gelatin are not covered in this guideline. So first question, should albumin versus crystalloids be used for volume expansion in adult critically ill patients in general? So according to this guideline, they recommend the use of crystalloids rather than albumin for volume expansion in adult critically ill patient. It is a conditional recommendation, and the certainty is moderate certainty of evidence. So advocacy for albumin use. So it is believed to be more effective in regaining the intravascular volume and maintaining the on-contact pressure. And according to early physiologic consideration, it suggested a 1 to 3 volume expansion ratio for albumin versus crystalloids, with less incidence of interstitial edema. And then there's also challenges to on-contact pressure theory, in which physiologists suggest filtration in microvessels also plays a role. And recent RCT findings showed that no significant advantage of albumin over crystalloids in patient-centered outcomes. And in SAFE trial, it showed that variable albumin to saline volume ratio of 1 to 1.2 to 1.6. So in terms of the mortality, there's little to no difference between albumin and also crystalloids, according to 16 trials with high certainty. In terms of the renal replacement therapy, there's no significant difference. Mechanical ventilation duration, no difference. ICU length of stay might not be affected. Hospital length of stay, little to no evidence, but evidence is uncertain. And regarding the quality of life, there's no data available from the meta-analysis. And balance effect, in terms of the cost, albumin is significantly more expensive than crystalloids. Cost effectiveness, there's limited data. Some studies show cost effectiveness in selected population, others do not, especially in low resources setting. Widespread albumin use may negatively impact the equity and availability. Albumin is often unavailable in resource limited setting. And there's also resource limitation in which albumin is derived from human blood, making it a limited resource. And generally, albumin is acceptable to most patients, but some may avoid due to blood product origin or potential of allergic reactions. So, in conclusion, given all consideration, the panel conditionally recommends crystalloids over albumin for volume expansion in general for patients who are critically ill. However, there's unresolved question and research gaps, and further studies needed on different albumin concentration. So between 20% and 5% albumin, and interaction of albumin effects with concurrent crystalloid administration also need further study. Question number 2, should albumin versus crystalloid be used for volume expansion in adult critically ill patient with sepsis? So according to this guideline, the recommendation is to use crystalloid rather than albumin for volume expansion in patient with sepsis. It is a conditional recommendation again, and with moderate certainty of evidence. So background, so sepsis is characterized by decreased vascular tone with increased venous capacitance and also capillary leak. And during fluid resuscitation, the fluid will distribute into the interstitial and intracellular spaces, especially because during sepsis there is impact endothelial integrity, which leads to loss of effect. And there's also interstitial edema, which is associated with organ dysfunction in sepsis. So the advantage of albumin, it has a greater plasma expanding capacity by maintaining the on-contact pressure. It also have several pleiotropic properties, such as it binds to the toxic substances and drugs. It has anti-inflammatory effects and also modulation of the hemostasis and also acid-base hemostasis. So summary of evidence, in terms of the mortality, there's no difference between albumin and also crystalloids according to 9 trials. In terms of the renal replacement therapy, no significant difference. In terms of the ICU length of stay, there is probably no effect. Ventilator-free days might not differ. Mechanical ventilation duration and hospital of length of stay, there's little to no effect. However, the evidence is very uncertain, and overall balance did not favor albumin over crystalloids. The evidence was moderate, and it was downgraded for imprecision. Additional consideration, also they took into consideration the cost and availability of the albumin is more expensive and less available compared to crystalloids. And then, however, specific patient groups have uncertainty regarding the benefits for hypoalbuminemia and also large volume of crystalloid and patient with septic shock. And SAFE trial sub-study, there's no clear benefit for low serum albumin concentration patient. So in conclusion, this guideline conditionally recommended for the use of crystalloid over albumin for volume expansion in patients with sepsis. However, there's a few unresolved questions and also research gaps that need further study, especially in fluid choices in sepsis phases, in different phases, such as the resuscitation phase, optimization, stabilization, and evacuation phases. They need further study. And then also the concentration of the albumin role as resuscitation fluid in sepsis is still unclear and need further study. And then specific patient group also need studies to evaluate if albumin improve outcome in patient with hypoalbuminemia and patient with that need large volume of crystalloid and patient with septic shock as well. Then there's also resource limited settings. In resource limited setting, we need to evaluation of the fluid choice, especially regarding cost effectiveness and analysis required across different setting and patient population, especially patient with hypoalbuminemia. Okay, so move on to the third question. Should albumin versus crystalloid be used for volume expansion in adult critically ill patient with acute respiratory failure? So in patient with acute respiratory failure, they also recommend the use of crystalloid rather than albumin for volume expansion. And the recommendation is also conditional with low certainty of evidence. So background, ARDS, major cause of acute respiratory failure, characterized by increase in the alveolar capillary permeability and also fluid accumulation in the alveolar space. So according to the fluid filtration, according to the traditional Starling model, it suggests that fluid filtration is determined by the difference in the hydrostatic and also the aquatic gradients. And then the interstitial space has a high protein concentration, limiting fluid return to the plasma compartment. So for optimal fluid, optimal fluid resuscitation, it should able to correct the hemodynamic instability and also improve the tissue perfusion. At the same time, avoid inducing pulmonary interstitial edema in patient with acute respiratory failure. So summary of evidence, literature search was done. There's 3 RCTs with 197 participants, comparing albumin and also crystalloid in patient with acute respiratory failure. Safe trial subgroup, 123 of 6,000, about 7,000 patients not stratified by acute respiratory failure. Other studies included 46 and 24 patients. So in terms of the mortality, there's no significant difference between albumin and crystalloid. Other outcomes, no other outcome reported for this population, and balance between benefit and harms did not favor either albumin or crystalloids. They also consider other considerations such as the cost, equity, availability, and patient preferences in making the recommendation. So in conclusion, according to the guideline, they conditionally recommend the use of crystalloid over albumin for volume expansion in patients with acute respiratory failure. However, there are still unresolved questions and research gaps, which includes lack of published trials on the effect of albumin or other fluids on patient-centered outcomes in patients with ARDS, and also the need for further studies on the cost effectiveness of albumin and its effects on long-term outcome in patients with ARDS. Move on to the next question, the question number 4. Should albumin versus crystalloids be used for volume expansion in adult critically ill patient with traumatic brain injury? So in traumatic brain injury, this guideline recommend the use of isotonic saline rather than albumin for volume expansion in patient with TBI. And the recommendation is a conditional recommendation with very low certainty of evidence. Remark, there is existing RCT data comparing isotonic saline but not balanced crystalloid versus albumin. So the current management of severe TBI currently is centered on maintaining the adequate cerebral perfusion pressure, necessitating the treatment with intravenous fluid and also vasopressor. And there's also concern about the safety of 4% albumin based on the subgroup analysis from the SAFE trial. Summary of evidence in terms of the RCT data, there's limited to subgroup analysis from the SAFE trial. In terms of mortality at day 28, there's higher mortality in the albumin group compared to the isotonic saline. And then in terms of the long-term mortality, there's higher mortality in the albumin group at 2 years. And then in terms of the neurological outcome, less favorable in the albumin group. as measured by the GOSE, and also driven by the patients with severe TBI with GCS score of less than 9. And then in terms of the intracranial pressure, higher intracranial pressure in patient with albumin group at the end of the first week. And then mechanistic insight, hypotonicity of 4% albumin solution, 260 milliosmol per liter hypertonic carrier fluid might contribute to excess mortality because of increased risk of cerebral edema. And also as evidenced by an animal study which suggests hypotonicity as a contributing factor to the negative outcome. So balance of benefit versus harms, it favors isotonic saline given very low sensitivity of evidence, cost and also equity consideration. And the sensitivity is very low, downgraded for risk of bias and also imprecision. In conclusion, they conditionally recommend the use of isotonic saline over albumin in TBI patients requiring fluid resuscitation. However, there is still unresolved question and also research gaps. For example, hyperoncotic albumin, lack of robust data on the safety efficacy of hyperoncotic human albumin solution in patients with severe TBI. And then move on to the question number 5. Should albumin versus crystalloid be used for volume expansion in adult critically ill patient in the perioperative period and in patient with bleeding or at risk of bleeding? So for this question, they recommend the use of crystalloids rather than albumin for volume expansion in patient in the perioperative period and also bleeding or at risk of bleeding, and it is a conditional recommendation with very low sensitivity of evidence. So background, dilutional coagulopathy can be caused, it can happen when because when we give large amount of intravenous fluid, they lack coagulation factors, so it will dilute the plasma and will impair the coagulation. And then volume efficacy as well, higher volume efficacy fluids, for example crystalloid, more likely to cause dilutional coagulopathy. And then in trauma study, low volume crystalloid replacement associated with reduced coagulopathy, blood transfusion and also reduced mortality. So summary of evidence, a systematic analysis by Sang et al. Identified 9 trials comparing albumin versus crystalloid in perioperative and bleeding or patient with risk of bleeding. So study context, 6 trials in major vascular surgery, 3 trials in trauma patient, which are mostly conducted more than 15 years ago. So according to the evidence, in terms of the mortality, there's no effect on the mortality according to the 9 trials. And then acute kidney injury, no effect in terms of the acute kidney injury according to the 1 study, but the evidence is very uncertain. Then blood transfusion volume, numerically smaller blood transfusion volume in albumin group, but not statistically significant. And then balance of benefit versus harm, it did not favor albumin or crystalloid and very low, however it's very low sensitivity and downgraded for risk of bias, indirectness and also imprecision. They also took into account the additional considerations such as cost, equity, availability and also patient preferences. And in conclusion, they recommend the use of crystalloid over albumin. And then there's still unresolved question and research gaps, which includes outdated evidence. So most of the evidence on this is based on older RCTs with limited outcome evaluation, and there's a need for a better understanding of the fluid choice and differential impacts across patient subgroups. So need for contemporary RCTs. Then question number 6, should albumin versus crystalloid be used for volume expansion in adult critically ill patient with cirrhosis? So in patient with cirrhosis, this guideline recommend the use of albumin rather than crystalloids for volume expansion. It is a conditional recommendation again and with very low sensitivity of evidence. So background, hemodynamic change in patient with advanced cirrhosis is characterized by increase in splenic blood volume and relative central hypovolemia. So for this type of patient, the benefits of albumin, is used to expand the intravascular volume. It also may provide antioxidant effect, anti-inflammatory effect, and also it has a toxin binding properties as well. So clinically, it's commonly used for patient with decompensated cirrhosis, ascites, encephalopathy, infection, hepatorenal syndrome, and also patient with hypoalbuminemia. Then summary of evidence. In terms of the systematic review, there are 3 relevant RCTs identified, focusing on critically ill and hospitalized patients with cirrhosis. In terms of the mortality, there's no statistically significant difference between albumin and crystalloids in 3 trials with 464 patients. In terms of the renal replacement therapy, ICU and hospital of length of stay, similar findings, no significant differences. However, the evidence is very low sensitivity. And then balance of benefit versus harm, it favored albumin over crystalloids, but overall sensitivity was very low due to indirectness and also imprecision. And they also took into account the cost effectiveness. Limited data, but one study showed albumin is cost effective for decompensated cirrhosis in Europe, and data from the low middle income countries are lacking. And in terms of the equity in cost, increased cost and reduced equity considered in the recommendation. So conclusion, conditional recommendation for using albumin over crystalloid for volume expansion in critically ill patient with cirrhosis. However, further research are needed to evaluate the albumin versus crystalloid for volume expansion in critically cirrhotic patient, and also further evaluation regarding the role of 20% versus 5% albumin in this population also required further study. Then next question number 7. Should balanced crystalloids versus isotonic saline be used for volume expansion in adult critically ill patient in general? So in general, they recommend the use of balanced crystalloid rather than isotonic saline for volume expansion in adult critically ill patient. Is again conditional recommendation with low certainty of evidence. And remarks, in setting with limited supply, prioritize balanced crystalloid for patients requiring large volume of resuscitation rate and those with hyperchloremic acidosis. Alternatively, isotonic saline is acceptable to be used where balanced crystalloids are unavailable. And specific cases, consider isotonic saline in patient with hypochloremia or patient with metabolic alkalosis. So background, isotonic saline is commonly used crystalloid solution with sodium and chloride concentration of 154 millimole per liter each, leading to zero strong iron difference and potential for hyperchloremic metabolic acidosis. So hypochloremia risk associated with acute kidney injury. And then balanced crystalloid, they have lower chloride concentration. They also include organic anions such as lactate, acetate, gluconate, and malate, and also additional cations such as potassium, calcium, and also magnesium. So summary of evidence, systematic review, Hammond et al. Identified 11 studies with 36,000 participants, 9 RCTs reporting mortality. In terms of mortality, no significant difference between these two groups. Then 90-day mortality, pool analysis of 6 trials showed RR of 0.96. And then Bayesian meta-analysis, posterior probability of reduced mortality with balanced crystalloid was 91.7% in all trials. And then about 89% in low-risk trial. And individual patient data meta-analysis or ratio for 90-day mortality was 0.962 with probability of reduced mortality at 89.5%. So overall findings, balanced crystalloid probably result in a slight reduction in the mortality, no difference in the renal replacement therapy, ventilation free days, vasopressor free days, ICU length of stay, and hospital length of stay. Balance of benefit versus harm favored the balanced crystalloid over isotonic saline. In terms of the cost availability, cost comparison, balanced crystalloid generally more expensive than isotonic saline. And in terms of the cost variation, significant variation across the countries, but in the US, 0.14 to 1.04 USD per 100 ml for balanced crystalloid, 0.09 to 1.04 USD per 100 ml for isotonic saline. And then equity consideration, limited availability of balanced crystalloid in low-income countries. So conclusion, conditional recommendation for using balanced crystalloid over isotonic saline for volume expansion in critically ill patient. And also, as mentioned, prioritize balanced crystalloid for patient needing large volume with hyperchloremic acidosis. And alternatively, use isotonic saline where balanced crystalloid are unavailable, and use isotonic saline in patient with hypochloremia or metabolic alkalosis. There's unresolved question and also research gaps that need further studies. Especially comparative studies are needed on different balanced solution. For example, plasmalite versus ringgit lactate versus acetate or patient-centered outcome. And then guided therapy trials, important for critically ill patient, including regular chloride measurement and prompt intervention for patient with hyperchloremia. And consider variation in fluid cost and laboratory tests across different settings. And then next, question number 8. Should balanced crystalloids versus isotonic saline be used for volume expansion in adult in critically ill patient with sepsis? So in patient with sepsis, this guideline recommend the use of balanced crystalloids rather than isotonic saline for volume expansion. It's again a conditional recommendation with low certainty of evidence. So background, isotonic saline is traditionally the most used resuscitation fluid in sepsis, but it is associated with increased risk of acute kidney injury due to high chloride content. And nowadays, the balanced crystalloids gain more popularity due to lower chloride content, and it also mimics the physiological levels. So summary of evidence, recent trials evaluated subgroups of patients with sepsis, including 6 studies with around 7,000 participants. In terms of mortality, balanced crystalloids compared to isolated saline probably did not result in statistically significant reduction in mortality. Bayesian meta-analysis, OR for 90-day mortality was 0.935 with a posterior probability of reduced mortality at 89.3%. So overall data suggested a slight reduction in mortality with patient with the balanced crystalloids group. And other outcome in terms of the renal replacement therapy and ventilation free days, there's no significant differences and probably no effect in the vasopressor free days. In terms of the balance of benefits versus harm, it favored the balanced crystalloids over isotonic saline. However, the sensitivity is low, downgraded for inconsistency and also imprecision. In conclusion, this guideline recommend the use conditional recommendation for the use of balanced crystalloid over isotonic saline for volume expansion in patient with sepsis. And further evaluation and study is needed to evaluate the effects of different balanced crystalloids on patient-centered outcome in sepsis patient. The next question number 9. Should balanced crystalloids versus isotonic saline be used for volume expansion in adult critically ill patient with traumatic brain injury? So, in this group of patient, they recommend the use of isotonic saline rather than balanced crystalloid for volume expansion. And the type of recommendation is conditional recommendation with low certainty of evidence. And most evidence is from RCTs using balanced crystalloid with near normal osmolarity. And avoid hypertonic balanced crystalloid, for example, ringgit lactate or acetate in patient with TBI because there is of cerebral edema. So background, fluid osmolarity critical in TBI management as low osmolarity can lead to cerebral edema. And then isotonic saline, reference solution with an osmolarity of 308, slightly higher than the normal plasma osmolarity. And balanced crystalloid have variation in the osmolarity, generally lower than isotonic saline. Ringgit lactate is slightly hypotonic and associated with higher TBI mortality in observational study. So summary of evidence. The systematic review identified subgroup data from 3 RCTs with low risk of bias comparing balanced crystalloid to isotonic saline in TBI patient. Balanced crystalloid use are plasmalite and also ringgit lactate. And from this, in terms of the mortality, there's increased mortality with balanced crystalloid group compared to isotonic saline. And then the ratio for mortality was 1.424 with a high posterior probability of 97.5% that balanced crystalloids increase mortality. And then in terms of other outcome, renal replacement therapy little to no effect but very uncertain evidence. Neurological outcome not reported. Discharge disposition is worse in patient with balanced crystalloids group. And overall certainty very low, downgraded for risk of bias, inconsistency, indirectness and imprecision. So in conclusion, according to this guideline, conditional recommendation for use of isotonic saline over balanced crystalloid for volume expansion in patient with TBI. and then avoid ringer's lactate due to observed harm in patient with TBI. And there's further research needed and more trials needed to compare different balanced crystalloid and their effects on patient-centered outcome in patient with TBI. And then the question number 10, should balanced crystalloid or isotonic saline be used for volume expansion in adult critically ill patient with kidney injury? So with patient with kidney injury, this guideline recommend the use of balanced crystalloid rather than isotonic saline. And it's a conditional recommendation again with very low certainty of evidence. So background, volume expansion NKI aims is mainly to improve the tissue perfusion and also maintain the fluid balance without further compromising the kidney function. So summary of evidence, relevant RCT, only one small RCT comparing balanced crystalloid to isotonic saline in pre-renal AKI with pre-established CKD. And the findings are no significant difference in short or long-term kidney function and none of the patient required dialysis. So indirect evidence, renal transplantation, data from RCTs including best fit trials were considered, and then pool data from 8 RCTs. So renal replacement therapy, balanced crystalloid might have reduced the need for RRT. Then mechanical ventilation might have reduced the need. Delayed graft function probably reduced. Hospital length of stay, no significant difference. And overall certainty very low and downgraded due to inconsistency in diagnosis and imprecision. They also put into consideration the cost and availability of the balanced crystalloid. They are modestly priced, but availability may be limited in resource poor setting. In conclusion, use of balanced crystalloid rather than isotonic saline is recommended for volume expansion in patient with AKI. And it is again a conditional recommendation with very low certainty of evidence. And further study is needed in terms of more data on the choice of balanced crystalloid versus isotonic saline for volume expansion in critically ill patient with AKI. And then the last question, should small volume hypertonic or isotonic crystalloid be used for volume expansion in adult critically ill patients? So they recommend the use of isotonic crystalloid rather than small volume hypertonic fluids for volume expansion in adult critically ill patient. And again, the recommendation is conditional recommendation with low certainty of evidence. And background, hypertonic saline solution investigated as an alternative for managing hypovolemia, hemorrhagic and septic shock due to immediate intravascular volume expansion with reduced administered volume. The advantage of hypertonic saline solution, it can improve the hemodynamic and has anti-inflammatory effects. It is beneficial for resuscitation, especially in battlefield and also in pre-hospital settings. However, the disadvantage, it has a high chloride content, which may cause acidosis, coagulopathy, and also impair renal function. In TBI studies, there's no improvement in the short-term or long-term outcome compared to the conventional fluids. So summary of evidence, literature review identified 17 RCTs comparing hypertonic saline to isotonic crystalloids in trauma, hypovolemia, sepsis, and surgery patient. So in terms of the mortality, there's no reduction in mortality according to the 17 trials. And in terms of other outcomes, the renal replacement therapy, ventilation-free days, ICU length of stay, and also functional outcomes, there's no significant differences. And there's very uncertain evidence according to the outcome of hospital length of stay, and overall certainty is very low and downgraded for risk of bias, inconsistency, and also imprecision. So balance of benefits versus sum, it did not favor the hypertonic saline over isotonic crystalloids. And also additional consideration, availability and cost. Hypertonic saline has variable availability and higher cost and has limited acceptability among critical care practitioners. So in conclusion, conditional recommendation for using isotonic crystalloid over small volume hypertonic fluid for volume expansion in this guideline. And also further research is needed to identify subgroup of critically ill patients who may benefit from hypertonic saline for volume expansion. So in summary, there are 11 conditional evidence-based recommendation. Generally preferred crystalloids over albumin, and then balanced crystalloid preferred over normal saline except for TBI patient. And then albumin may be preferred in patient with cirrhosis. And then isotonic saline preferred in TBI and limited setting. And also further research are needed to personalize the fluid therapy according to the patient context. And this is the recommendation from this guideline, 11 recommendation. So general ICU patient, preferred fluid crystalloid over albumin. Certainty is moderate. Recommendation all are conditional. Patient with sepsis, preferred fluid crystalloid over albumin. Patient with ARS or ARDS, crystalloid over albumin. TBI, isotonic saline over albumin. Patient with perioperative patient with bleeding risk, crystalloid over albumin. Patient with cirrhosis, albumin over crystalloids. And then in general, balance crystalloid versus normal saline. So balance favored over isotonic saline. And then in patient with sepsis, they favored the balance crystalloid over isotonic saline. Patient with TBI, isotonic saline over balance. And then AKI, balance over isotonic saline. And in general, hypertonic versus isotonic. Isotonic are more favored over hypertonic solution.
Okay. Thank you, Syahidah. Any questions from the floor or online? So before that, Syahidah, can you just go back to the section on cirrhosis, albumin versus crystalloid. Okay, can you just go to the next slide? Actually, from these guidelines, what did the authors? Why did the authors actually recommend albumin over crystalloids, even though in your highlighted summary of evidence, there's not much, there's no significant difference in terms of all the outcomes.
I think because of the benefit of albumin in patient with, in terms of the physiological changes in patient with cirrhosis. So the albumin may provide more in terms of the volume expansion, and also they also have antioxidant properties and pleiotropic properties as well. And also usually this patient also have hypoalbuminemia.
So are you just referring to theoretical benefits versus tangible ones that the authors were considering? Yes. Okay. All right. Any questions so far? So while we don't have any questions at the moment, so Syahidah, what is your takeaway from this guideline, and how does this affect your daily practice, or how do you view your daily practice in the in light of these recommendations?
So I think so for fluid resuscitation in patient actually differ according to the context of the patient, so according to the cases. But in general, to be safe, we should use the crystalloids as the main choice of fluid for resuscitation. But of course, according to the different cases and also context of the patient.
So looking at the recommendations, I think the overwhelming recommendation has been just a conditional recommendation. So in light of that, how do you view your practice, and how will it change your practice in the future?
I think again, because it's conditional recommendation, so each patient differs. So I think it's very important for us to really see the patient from time to time, especially in critically ill patient. The condition can change, and also the parameters, blood parameters and all can change in a matter of minutes and hours. So I think it's very important to see the patient context when deciding on the fluid resuscitation.
Okay, can you just go back to your last page summary? Okay. Personally, my own opinion about this recommendation has been that in general, the more we think we can change things, the more they actually do not change things. So of course, we like to use balanced solutions over isotonic saline, but in a lot of but when they look at it at a bird's eye view, it's very difficult to see whether our choices actually make a difference in terms of patient outcomes. And if you look at, for example, like in TBI, uh, probably not so much of the albumin, but maybe because of the hypotonicity of the solution itself that's causing the problem. And then if you look at AKI, a lot of these trials rather than retrospective studies actually you have to go to the most extreme of the patients. The most extreme being the end stage renal failure patients. So a lot of these studies which show that balanced solution is better than normal saline is actually in all these ESRF patients who undergo transplant, like you highlighted. So in all these transplant populations, you might think that your best fluid is normal saline, but actually it is these trials that show that using balanced solutions provides a better outcome in terms of the immediate post-op, like in terms of hyperkalemia incidents, acidosis incidents, need for RRT, and in terms of early or delayed graft function, all very slightly favors balanced solutions. And even when you look at that higher mortality risk in TBI, it's mainly a observational thing. So I think the takeaway is, of course, we have our own personal biases in the fluid that we want to use, but it's very difficult for us to criticize another practitioner's different choices. So let's say if someone likes to use albumin while you do not, is of course you can probably criticize in terms of the cost effectiveness, but like looking at, let's say if somebody wants to resuscitate fully with normal saline while you like to use Hartmann, it's difficult for you to criticize that particular choice as being harmful to the patient, because in general, in most situations, the outcomes, the tangible outcomes, are generally the same. So, Syahidah, when we talk about TBI, is normal saline our only crystalloid choice?
Crystalloid choice.
Do you have crystalloids that are theoretically compatible in the setting of TBI?
Stereophonic but colloid, right?
What? Are you saying stereophane is a colloid? Are you sure that stereophane is a colloid? So stereophane is a crystalloid. So what's the difference between stereophane and Hartmann? I mean, okay, how do we achieve that so-called balanced solution composition? I mean, from normal saline and you change it to become Hartmann, or you change it to become stereophane, what must you do? Lactate, okay, and then in stereophane, acetate maleate, what you mentioned. Okay, so why do we sometimes use stereophane in the neurocritically ill, but not Hartmann? What is the main difference? What about it?
Because Hartmann has hypo, is more hypo, so tendency to develop several edema in TBI patient, and as compared to stereophane, it has a higher osmolarity compared to the.
Okay, so sterophandine's osmolarity is 309, which is basically more or less the same as your normal saline. So that's why we sometimes use it, especially in the setting of hyperchloremic acidosis. Okay.
I think I read somewhere regarding the benefit of hypertonic saline in patient with TBI to reduce the risk of.
Okay.
It doesn't mention in this.
In here their focus is on fluid expansion, right? So you need to remember that in this particular guideline, their focus is in terms of fluid expansion, not really in terms of the use of hypertonic saline in managing intracranial hypertension. So of course, if you want to manage intracranial hypertension, then if you want to use hypertonic therapy, then you can either you have mannitol or you have hypertonic saline. But there is for a different indication than pure fluid expansion. Okay, so like in the high bleeding risk, in general, let's say in the very severe trauma, so what is the general target in terms of fluid therapy? Just enough perfusion. So damage control resuscitation. So wait, go back to your page on the perioperative / high bleeding risk. Okay, what does it say there in terms of in the background? It's already there.
So risk of dilutional coagulopathy.
So how do you get dilutional coagulopathy?
Because of the use of high volume crystalloids.
Okay.
Which lack of the factors.
Okay. So what does it what does your third sentence say?
In trauma study, low volume crystalloid replacement associated with reduced coagulopathy, but transition and also mortality.
So which means give as little as possible. So you are going to accept a lower blood pressure until the damage control or definitive surgery is obtained. Because the more you give fluid, the more you're going to dilute your coagulation factors. What else? People used to talk about the lethal triangle. Some people want to correct me saying now it's a diamond. What are the three corners that they're talking about? You give a lot of fluids, okay, you get coagulopathy, dilutional. What happens further when you give a lot of fluids? Hypothermia, okay. Then what else? Acidosis. So people used to say the lethal triad of trauma would be dilutional coagulopathy. I mean, it's not necessarily dilutional. It's all basically a tool towards a ravine. So coagulopathy causes more bleeding. More bleeding causes acidosis. More fluids causes acidosis. More fluids also causes the temperature to drop. More fluids causes coagulopathy. All will exacerbate the other. And then the other fourth thing that they talk about is hypocalcemia. So now they are saying that in severe trauma, you have to think about all of these four aspects and not just three, in order to ensure adequate resuscitation. People in the past all talked about giving a lot of fluids. So you need to remember that in medicine, we tend to swing one side to the other. So in the past, initially we only had blood. Everything was good. Then starting in the Vietnam War, then people gave a lot of crystalloids. And then you have all these danang lang, basically post-trauma ERDS, which is because of crystalloids. And then what happened with the US war in Iraq and Afghanistan, then they talked about damage control resuscitation. And then suddenly fresh blood and suddenly is back in favor again. And then that's how you come about with your 111 regime, right? It's all because of these military medicine studies looking into trauma. So from blood, and then suddenly you go to plasma, and then now you go back to the other way. So you need to remember that in medicine, don't be swayed by the newer stuff, because your newer stuff may not be looked back kindly in time. So just like when you look at this particular guideline, all of basically in summary, they can just summarize it as what you choose doesn't matter. And in that case, choose the one that is cheaper. Correct. Okay, any other comments or questions? Okay, so if not, we shall thank Syahidah in the usual manner.